Hello and welcome to this presentation on an orientation to hospice care. We want to welcome those of you who provide ambulance services to our patients living in your communities. We appreciate this opportunity we have to share a little bit about our services and the difference we are making in the lives of patients and families in your communities. I'm Gary Bohannon. I'm a Senior Director here at Hospice. I've been involved in this work for over 23 years now and know the kind of difference it can make in the lives of people who are going through very serious circumstances in their life. Today we want to share with you different aspects about our work and how we can partner with you to deliver great care to our patients and families. Today we're going to cover several topics, and we hope at the end of this you will have a better understanding of each one of these areas. First, we're going to look at our hospice philosophy of care, and then the delivery of care. Who's eligible for our services? How do we deliver these services to the patients and family? How are these services paid for? And then some common misconceptions that people have about end-of-life care. We'll also talk about patients' rights, and then we'll finish with a special subject that's of special interest to you, EMS DNR orders and hospice patients. What is hospice? Hospice is hospice care. We are a not-for-profit organization that provides care, end-of-life care to patients and families living in 33 counties in Kentucky and southern Indiana. We are a not-for-profit organization. We are mission-driven, and we are supported by our communities to provide this care to patients and families. Each year we serve over 5,000 patients. Our census varies anywhere from 800 to 900 patients a day. So it's quite an undertaking that we have here in providing specialized care to people who have very serious medical conditions. Some of you may wonder about our name. Why are we called hospice and not hospice? One of the reasons we're called hospice is in some of our areas there is more than one hospice provider, and we want to be able to distinguish our organization from other hospice organizations. Also, we call ourselves hospice because we are a regional provider. We provide to, as I say, many counties in our community, and we wanted to be able to come up with an identity for ourselves as a regional provider. But most importantly, the reason we came up with the name hospice is because when we did research and found out what families especially appreciated about the care their loved one received from us, one of the things that kept coming out is we really appreciated the fact that you helped explain things, that you helped guide us through these last days and weeks and months of our loved ones' lives. So we understood what was going on and we knew what was helpful and what wasn't. And so our name was created to reflect that guidance that hospice provides to its patients and families. Hosp, which comes from the same word hospitality, which means guest, par, across, and us, we. We guide our guests. That's what hospice means, and that's what we do. We guide our patients and families through a very difficult transition in their lives as their loved one comes to the final chapter of living. As I mentioned earlier, we serve a very large service area, 33 counties in all, up in southern Indiana and then down through the central part of Kentucky. You may want to call us Hospice of I-65 since it seems like we serve many of the counties on either side of that interstate and along that I-65 corridor. Our mission is improving the quality of life. What exactly does that mean, though, for someone who has a very serious illness? A couple of examples of how hospice can improve the quality of life of someone who is dealing with a very serious health problem. One of our patients, Jimmy Pierce, was a hospice patient who was in hospice care because he had advanced cancer. His cancer was so painful before he came into hospice that there were times when he would just lie down on the floor and curl up into a ball because the pain was so intense. And then he was admitted to hospice care, and our nurses were able to work with him, our nurses and physicians were able to work with him and get him the kind of medications and treatments he needed so that we could get that pain under control so he was comfortable again. One day, Jimmy's grandson came up to him and said, "Papa, can we go fishing?" And Jimmy said, "Well, I don't know. Let me ask the hospice nurse." And so Jimmy asked the hospice nurse, and she said, "Well, as fine as you're feeling comfortable, go ahead. Please go fishing with your little grandson." And so Jimmy went fishing with his grandson. Later we asked him how that went, and he said, "Well, we didn't catch many fish that day, but I did get to see my grandson catch his first fish." Jimmy is no longer with us, but the memory of being able to catch his first fish and his grandpa being able to be there has brought tremendous comfort to that family now that he is gone. You know, I always like to think of the commercial, the American Express commercial, the cost of the fishing pole, the cost of the bait, and then the price of being able to see your son catch his first fish. You know, that's priceless. And so Jimmy was able to have that experience because hospice was involved. We were able to get his pain and symptoms under control so he felt well enough to be able to go out and see his grandson fish that day. Sometimes the pain isn't a physical pain, the suffering isn't a physical suffering, sometimes it's emotional suffering. I remember another situation where we had a patient who he had been married for quite some time, and one of the things that was concerning to him, he'd been married over 60 years, and one of the things that concerned him was that he wanted to be able to let his wife know just how much he cared for her and loved her and how much he appreciated her. And this was really troubling him. And so he discussed it one day with his chaplain, and his chaplain said, "Well, are you familiar with the marriage vow renewal ceremonies?" And the patient said, "Well, I'm not familiar with that. Can you explain that?" And so our chaplain explained what it meant to have one of these marriage vow renewal ceremonies. And the patient said, "Well, that's great." And so the patient and the chaplain discussed it with the patient's family, and they all thought that was a great idea. So there in the patient's home, the patient was in a hospital bed that hospice had provided, seated next to his wife, and they're holding hands, and the family had gathered around. They even brought in a wedding cake. And the chaplain there led the couple through this marriage vow renewal ceremony. It was a great celebration of the 60 years of marriage that this couple had shared together. And it was a way for that patient to be able to express to his wife just how much she meant to him and how much her love had meant to him through his life. And so after that day, the chaplain said that the patient was much more at ease, much more at peace, because he had had this experience. He'd been able to tell his wife one more time in a very special way just how much she meant to him. And so hospice is there to improve the quality of life of seriously ill patients, both physically as well as spiritually and emotionally. Our hospice philosophy. Hospice is not about dying. Hospice is about helping people to live fully until the end comes. And I think those two stories that I just shared with you very much illustrate that. We want people to be able to live as fully as possible within the limits of their physical condition. Because even though these may be the last part of life, they can still be days rich in meaning, days that are very precious to the patient and family. We see at hospice, we see death as just part of life. It's the dying process is just a natural part of life. And so we don't try to deny it. We know it's there. But at the same time, we know that there's still some living to do until that time comes. And we try to help families prepare for that time and to make the most of what time they have left together. Hospice neither hastens nor postpones death. We are not there to hasten the person's death, yet at the same time, we are there when the person allows the natural processes to take place so that they have a natural and as peaceful a death as possible. Hospice is different from other healthcare providers, whereas other healthcare providers are primarily focused on the quantity of life, how long they can keep a person alive. Hospice has a different focus of care. Our concern is the quality of life that that person is experiencing. How rich is their life? How meaningful is their life in that last part of their life? Who receives hospice care? Well, hospice care is available to all ages. Some people think, well, hospice care is just for seniors. But while most of our patients certainly are senior adults, we have patients who are middle-aged, people who are young adults. We even have children and infants who receive care. It's anyone who has a life-limiting illness. Also, we provide our care in a variety of settings. Some people think, well, hospice is just a facility. And while we do have a place where an inpatient facility where people can come and receive care, most of our patients live either at home or in a nursing home or assisted living facility. So we try to bring the care when possible to where that patient lives, because that is the place where that person is most comfortable. Also, since we are a not-for-profit, a mission-driven organization, we feel that our services need to be available to all persons. We do not want to see a person's economic situation be a barrier to them being able to receive this care. So as long as the person is medically eligible for the care, we will find a way for them to be able to get that care. We don't want their economic circumstances to be a problem. I mentioned before, hospice is available for people with any kind of life-limiting illness. In most situations, we usually think of things such as cancer, but there are also other conditions we provide care for. A COPD, people who have serious respiratory illnesses, a CHF, people with heart disease, advanced heart disease, dementia, Alzheimer's. My mother received hospice care. She had Alzheimer's, and during the last part of her life, she was receiving hospice care down in Georgia, and I'm very appreciative of what that group was able to do for her and how they supported her and my family through that time. Some of our patients are eligible because they've had a stroke. And then in some cases, we have situations where a person's had ALS or Lou Gehrig's disease. Again, they are eligible for our care. Our care is very patient and family-centered. One, it's patient-centered. We want to determine, one of the first things we go and determine is what's important to this patient. What do they want in this last part of life? Our care is also focused on the family because we know that when a person is seriously ill, it not only impacts that person, but it also impacts the circle of family and friends around that person. And so we know they also need support and care. And so our hospice team goes in and provides care for them as well. We focus on the whole person, not just the physical, but the mind and the spirit as well, and the emotions. A good example of that comes from a story I heard from Ira Bach. He's a medical director of a hospice out in the Midwest. They had a patient one time. His name was Jake. This particular patient had kind of a rough and tumble life. He was a ranch hand. He bounced around from different ranches out in the West and Midwest. And now he was in his 40s, and he had lung cancer. And so he was admitted to a hospice out there in the Midwest, and they were able to get his physical pain under control, but he was still suffering greatly, and his suffering was because of spiritual and emotional relationship issues that he had. One was his relationship with his Creator. And so when he said there were some things in his life that he really regretted. He hadn't really lived the life that he knew he should have lived. And so the chaplain came in and was able to work with Jake and help him to understand that God is a loving and forgiving and accepting God, and was able to help Jake find a sense of peace in his relationship with his Creator. But still, there was another area of relationship that was also troubling to Jake, and that was his relationship with his family. He was divorced and estranged from his ex-wife. He had 2 daughters. He was also had an estranged relationship with them. And then he lived at home now with his mother while he was being cared for with hospice. And there was some conflict there with his mother as well. And so he knew he needed to be able to deal with that. And so he struggled with that. That's something that caused him a lot of anguish about his relationship with his family members. And so when Ira Bach was talking with him, Ira Bach said to him, a hospice nurse once told me that there are 5 things you need to be able to say to a person to really have a complete relationship with them. And Jake said, well, what are those 5 things? And Dr. Bach said, Will you forgive me? I forgive you. Thank you. I love you. And goodbye. And Jake said, well, that's good. Can you write that down? And so the doctor took out his prescription pad and he wrote down those 5 things. And the next day, Jake called his family into his room there at his mother's house. He was in a hospital bed. And he called his 2 daughters and his mother and his ex-wife. And they all came in. And he said, while I still have a chance, there's some things I need to talk with you about. And the first thing I want to ask is, would you all please forgive me? He says, I know there have been times that I've disappointed you, times that I've hurt you with some of the decisions and actions of my life, and I just want to ask if you could find it in your heart to forgive me. And then he went around and told each one of them, I want you to know that I have, if you've ever disappointed me or let me down, I've put all that in the past. I hold no grudges. I've forgiven everybody. I hold nothing against anyone, so I've forgiven everybody. And then he said, thank you, and he went around and specifically thanked each one for something that they had done for him, how they had helped him during his life. And then he said something that he didn't say very often. He said, I love you, to each one of his family members. And then he said, while I still have a chance, I want to tell each one of you goodbye. When the hospice team came back the next day, they couldn't believe the difference that they found there at Jake's home. Before, whenever you would go there, you could almost feel the conflict in the home. You could cut the tension with a knife. It was a very unsettled feeling whenever you would go, atmosphere there in the home whenever you would go into it. But when they came back this time, there was such a sense of peace and calm to that home. And it's because Jake had been able to find healing in his relationship with his Creator and healing in his relationships with his family member. And even though he eventually passed away, he couldn't find that physical healing. He was able to find a spiritual and a personal, emotional relationship healing with his family. And those are the healings that ultimately are the most important. And so hospice can provide that kind of care, not only the physical care, but also that spiritual and emotional care that are also important to a person's healing. Hospice care is provided by an interdisciplinary team. We have a team of professionals that come into either the patient's home or nursing home or assisted living facility and provide the care. We have nurses who are trained especially in comfort care. They are very good at coming into situations where a person is having intense pain, or they're having difficulty breathing, or nausea, or restlessness, and they're very good at coming in and able to get those symptoms under control so that the person can feel comfortable and calm and able to breathe easily. And so that's one of the key services we provide is through our nurses, that comfort care. We also have a physician who is in charge of the care and directing the care, and if needed, the physician can also come to the patient's residence and provide care directly there. But the physician is always providing oversight to the care. We also have social workers who can come out and help the family with things like living wills, advanced directives, power of attorney, those kinds of legal issues. If the person has any kind of veterans benefits or there's some insurance issues, they can be very helpful with those sorts of things. We have a chaplain who's available to help if there are any spiritual needs that need to be addressed and the patient or family members don't have a minister that they feel particularly close to, or a family of faith or a community of faith that they're not attached to. The chaplain is available to come and help deal with any spiritual issues that might arise with the patient or family. We have health aides who can come into the patient's home and facility and provide personal care. They can come in and bathe and help with the personal grooming. And for someone who's had to be in bed a long time, that can mean so much to be able to get that kind of direct care. We also have volunteers who can come in and help provide emotional support to the family. Sometimes the family member, if you've ever had to care for a loved one at home, that's a very demanding responsibility. And so to be able to have a volunteer who can come in and sit with the patient for a couple of hours and watch the patient and provide emotional support to the patient so that the family member can go and run an errand or just take a mental health break. It's a great service to the patient and family. And then we also have grief counselors. Even after the patient passed away, for 13 months, a hospice provides a bereavement care. We have specially trained grief counselors who can provide individual counseling as well as group counseling, as well as some wonderful information to help people deal with the pain and sadness of their loss and help them to be able to work through their grief in a healthy way. As I've mentioned earlier, our services are provided in a variety of settings. Most of our patients, about 66% of our patients live at home. When you ask people, where would you, if you knew you had a limited amount of time, where would you like to spend that time? Usually about 70% of people say, I'd like to be able to spend whatever time I have left at home. That's where I'm most comfortable. That's where I have the easiest access to my family and friends. That's where I'm surrounded by things and people I'm most familiar with. So most of our patients were able to provide the care and they're able to stay at home and cared for by their families. Also, we provide care if the patient happens to be in a nursing facility or an assisted living facility. In my situation with my mother, she was in an assisted living facility. She and my father were in an assisted living facility down in Georgia. And so the hospice team was able to go in and provide the care for her. And because they were in there helping my dad with his care of my mother, she was able to stay there in the assisted living facility and didn't have to go to a nursing home. So it can be a great support to the patient and family by bringing hospice in. And then we also provide care in the hospital. Sometimes if there's a situation where we are not able to get the pain under control at home, we will sometimes send them to a hospital temporarily to take even more aggressive measures to try to get that pain or symptom under control. Usually this is just for a short period of time and we're able to get them back to either their home or nursing home or assisted living facility. We do have an inpatient facility in Louisville at the Norton's Healthcare Pavilion. It's a 25-bed, specially dedicated unit just for hospice's patients. We also have contracts with many of our hospitals in the 33 counties where we provide care so that we can provide hospice care even while the patient is still in the hospital. They don't have to be discharged and come home before we can provide the care. We can still provide that care even in a hospital setting. How do these services get started? Who can make a referral? Well, the truth is anybody can make a referral. It doesn't have to be a physician who makes the referral. It could be a family member, it can be a physician, it can be a nurse, it can be one of you who provides ambulance services, it can be a friend. Anybody can make a referral to hospice. What happens when we get a referral is we will contact that person and set up a meeting with them. We will go out and assess the patient to see if that patient is appropriate for our care. We will explain all of our services. The patient and family is under no obligation to come into hospice's care. And the visit is free. There is no charge with the visit. We can come in, explain our services, assess to see if the patient is appropriate. If the patient is appropriate, if the patient does want our services, we can contact their physician, get the physician's orders, arrange for any equipment that needs to be brought in, and have them scheduled for team members to start coming out and providing care. We handle all of that. We try to make this transition as easy as possible because we know this is a very difficult time for a patient and family. And so we work very hard to make this process as easy as it can be for the patient and family. If we do one of these educational visits and the family chooses not at that time to come under our care, that's fine, that's no problem. They are under no obligation to do so. And if later down the road they decide they do want to come into our service care, we can come back out and explain over again and contact their physician and handle all the arrangements. Again, we want to make this process as easy as possible. Anybody can make a referral. I think what happens sometimes is people expect the physician to make the referral, and then when we talk to physicians, they'll say, well, I was waiting for the patient and family to bring up hospice care. And so, unfortunately, what happens is Hospice care is designed for the last 6 months of life, but about half of our patients are with us just 2 weeks or less. And that's very frustrating to us because we know that person didn't get the full benefit of our services. So we want people to, whenever they think hospice care may be starting to get appropriate, to give us a call. We will come out, explain our services, find out if the patient is appropriate, and then admit them to our care so that hopefully they can get the full benefit of the hospice service. How is this care paid for? Because what we're talking about here is not only the visits from these professionals, the nurses, social workers, chaplains, the health aides, all their visits. We're also, hospice provides any medications related to the life-limiting illness. We provide any medical equipment like hospital beds or oxygen supplies, any of the drugs that are related to the life-limiting illness. All that's provided by hospice. So who pays for all that? Well, most of our patients are covered under the Medicare hospice benefit, which pays for the whole thing. So it's really a terrific benefit that many people need to be using because it does cover so much. Others are covered under the Medicaid benefit, and those who may not qualify for Medicaid and Medicare, in many cases their insurance policy will cover hospice care. And again, most of these cover the whole thing. Some of the insurance, there might be a small copay. For those who aren't covered under insurance or Medicaid and Medicare, our social workers will work very hard to find a way so that they can get the services. We do fundraising so we can provide this kind of care to folks who don't have a payer source because we feel that everyone should have hospice care who is medically appropriate for that care. There are some common myths and misconceptions about hospice care, and I want to review some of those with you because I think these are some of the barriers that keep people from getting the care and getting it at an appropriate time. One of the misconceptions is that hospice hastens death. Somehow we're like a Dr. Kevorkian who participated in assisted suicide. That is not part of our philosophy. We do not hasten a patient's death. Now, you may hear somebody say, well, this person was admitted to hospice and a couple of days later they passed away. Well, the truth is they would have passed away in 2 days whether hospice had been involved or not. Hospice did not hasten their death. It would have occurred whether we were there or not. There have been studies that have shown that when people are under hospice care, especially if they are under it for 1 or 2 months, that sometimes that can even increase the length of their life. They did a study once of lung cancer patients, and they looked at a group who were under hospice care and a group that wasn't under hospice care. And surprisingly, the group that was under hospice care, on average, lived longer than the ones who were not under hospice care. And so while hospice is not designed to necessarily prolong a patient's life, there are situations where it can just because of the support and comfort that they can give to their patients and families. Another misconception people have about hospice care is that it's just for cancer patients. When I first started in hospice back in 1990, about 90–95% of our patients were cancer patients. But in recent years, we've been able to start serving more of those patients who have the non-cancer conditions, such as serious heart and respiratory conditions, dementia patients, Alzheimer's patients, stroke patients, patients that traditionally didn't come under hospice care. Now more and more of those patients are under our care. In fact, more than 50% of our patients today are non-cancer patients. Some people, again, think hospice care is designed only for the last days of life, that we really shouldn't bring hospice in until those last days of life. But hospice is designed for the last 6 months of life. And again, unfortunately, many of our patients, half of our patients, are only with us for 2 weeks or less. And because of that, they don't get the full benefit of our services. Because of that, the families don't get the support that would have really benefited them in those earlier days and weeks and months if only that patient had been admitted to us sooner. And then there's also the conception that hospice is giving up. No, it's not giving up. It's just refocusing your hope. Instead of a long-term hope, it's more of a day-to-day hope of looking at the here and now and what can you do to make each day of life that you have left the best day it can possibly be. Some people also think that we're like home health because in many ways we're similar to home health in that our care is brought to a patient's residence. And there are some similarities, but there are some differences as well. One of the biggest differences is the people we serve. Home health is designed for people who are going to recover. It's for rehabilitation. In our situation, the patient's disease has progressed to a point where recovery is really not a possibility. These are people who are going to continue to decline. So two very different populations that hospice and home health serve. Also with home health is very limited in the number of nursing visits and the number of health aid visits that can be made to that patient, depending upon the patient's diagnosis. In hospice care, there is no limitation on the number of nursing visits and health aid visits that a patient can receive, no matter what their diagnosis is. Also, hospice is able to provide social work services and chaplain services, and those are very helpful to the patient and family as well. In addition, we have volunteer visits. Volunteers can come in, and those can be a big difference as well. Let me talk this next few minutes just about patients' rights. Patients' rights are very important to us. We are very patient-centered care, and we believe patients have certain rights, and we want to be respectful of those rights. And we want to work with our partners to also see that those rights of our patients and families are respected. First of all, the one that's important to us is access of care. We want every person in our community who is eligible for hospice care to be able to receive that care. That's why we have these kinds of training films as well as other things to help educate the community so that people know that hospice is an option and when it might be appropriate so that they can get that care as soon as possible. Again, we are not-for-profit. We want people who need our care, no matter what their financial circumstances, to be able to get that care. So access to hospice care is very important to us. Also, we're concerned about the dignity of a patient. We want the patients to feel respected. Even though we realize they are in a very vulnerable position, and so we want to respect whatever their wishes are regarding end-of-life care. We work very closely with the patient and family. We want to know what their goals. It's not about our goals, it's what their goals are. It's how they want to live out the last part of their life and how we can support them in doing that. Also, we know a timely response is important. Those hours, those days, those weeks are very precious to a person who's near the end of life. And so we provide 24/7 admissions. If a patient needs to be admitted to hospice care, whether it's after 5 o'clock in the afternoon, whether it's on a weekend, or whether it's on a holiday, we can admit a patient at any time of the day or night or weekend or holiday because we know it's important. And when a person makes that decision, they need hospice. And so we want to get there as soon as possible. And so responsiveness is important to us. We also want to provide them with information. As I said earlier, one of the things that came back to us when we talked with our families was they really appreciated the information we were able to give them to help them explain, to help them understand what was happening to their loved one and how they could help that person during that last part of their life. So informing the family, keeping them up to date on what's going on with the patient and the changes that are happening and how they can best address those changes. We also focus on pain and symptom control. As I said earlier, that's one of the primary services we provide. We know that people cannot be able to get the best out of life if they're in tremendous pain or if they're having difficulty breathing or if they're restless, and so we work very hard to get those symptoms under control so that the person can enjoy a good quality of life. And then choice. We want people to be able to choose what level of degree they want end-of-life care, how aggressive or not aggressive they want their end-of-life care to be. In addition, privacy and security are other important patient rights. We train our staff in all of the HIPAA standards. We want to ensure that the information about their loved one is protected, about the patient and family is protected. We do not want that information to fall into a person's hand that's unscrupulous and would misuse that information. So we work very hard to protect the privacy of our patients. We do not share patient information. We only do so with other healthcare providers on a need-to-know basis. And we make sure we have contracts with those providers so that they too are following HIPAA standards. We provide professional care. All of our care providers, many of them have advanced degrees. Our social workers and chaplains all have master level training. We use RNs, nurses, our health aides are all certified. Our volunteers go through extensive training. Our counselors, our bereavement counselors also have received licensing and training. So this is very professional care that's provided to the patient and the family. We encourage the family, and we want the family to participate in the development of the plan of care. We want them to be the one directing it, what's important to them, what are the priorities to them. We want them to be the focus of our care. They can refuse a treatment if they do not want to have medications to treat an infection. We respect that. If they want to discontinue with tube feedings, we respect that. We respect their right to refuse additional treatments if that's what they desire. We also have a process in place. We share this process with our patients and families if they ever have any grievance or complaint. We are a Joint Commission accredited organization, and we adhere to Joint Commission standards. We hold ourselves to the higher standards of a Joint Commission accredited agency. And so if a person has complaints or concerns, they can either contact Joint Commission, or if they need to, OIG or whatever group, they need to share their complaints or concerns about the care. If they don't get satisfactory answers from us, we have a system in place for them to share those with other regulatory bodies. Now here's an issue that I know is of concern to many of the folks who work in EMS, and that is what do you do in a situation where you are called out on an emergency call, you get a 911 call to go to the home of a hospice patient. You know, sometimes you have situations where a family member comes in from out of town, they aren't aware of what's been going on with the patient, they don't understand hospice care, and they will call you to say, come out and help the patient. What we do with our patients is we work very hard to train them not to call 911. We work with them to call us first, to call our nurse first. We have a nurse who's on call 24/7, and we say, if you need care, call us first. Don't go to the emergency room, call us first. If they need to go to the emergency room, then our nurse would contact the ambulance service to have that transportation arranged. But if in a situation where the family, for whatever reason, decides to call the 911, we also work with our patients to get an EMS DNR form signed. And usually that is attached to either the bedside, right at the bed of the patients, on the headboard or someplace close to the bed, or on a refrigerator of the home, because we want to be very visible. So if you, for whatever reason, you do find out they are a hospice patient, please ask about the EMS DNR form, because usually that form has been signed by the patient and family. We don't want to be putting you in an awkward position, and we work very hard to try to help our patients understand what would happen once EMS is called. We know you have protocols you have to go by, and if a DNR form is not there, you have to begin aggressive treatment. And so we work very hard with our families to educate them about when aggressive treatment is appropriate and when it isn't, and to let our nurse be the one who decides when it's appropriate and when it's not appropriate, and not try to call you directly, but to have our nurse make the one who makes that call. In conclusion, I want to leave you with a word from our founder. The hospice movement began in England. The lady who started it, her name is Cicely Saunders, and she passed away here just a few years ago. But she left us with this wonderful quote that sort of sums up the whole philosophy of hospice care. It says, "You matter to the last moment of your life, and we will do all that we can, not only to help you die peacefully, but to live until you die." And that's what hospice is about. It's not about dying, it's about living. Right now, I'm getting ready, my daughter is getting ready to give birth in a couple of months. And it's going to be my first grandchild. And it's really been interesting to see all the support she and her husband have been getting as they get ready for this big event. You know, the baby showers, all the support, all the encouragement, the cards, the words of support, the special care that she's getting from her physician and the physician's team of workers. And then when she goes to the hospital, they'll have the nicest room available for her in the whole hospital so that she can get the best kind of care. Because we want any newborn who comes into this world to be surrounded by love and to get the best possible care. Well, we at Hospice believe that people who are leaving this world also deserve that same kind of loving support. They need to be surrounded by a team that cares about them, that loves them, that will support them and their family through this important transition. And so that's why we're there, and that's why we appreciate the opportunity to partner with you to make sure that those in your community can get this kind of care and support. We're sending along with this training some additional information. If you ever have any questions of us, you can contact us at our website or you can call us. Here's the number where you can reach us, 800-264-0521. We'd be glad to answer any questions that you have. And again, we're thankful for this opportunity to be able to partner with you to make a difference in the lives of patients and families in the communities that we serve. Thank you.